CT scan shows a 3-centimeter rounded lower lobe mass, pleural thickening with bronchomascular markings, coursing from it towards the hilum and a curved path, diagnosed rounded atelectasis. This is called Crowe sign. Bronchomascular markings, vascular markings coursing from it towards the hilum and a curved path, diagnosed. This is called Crowe sign and is seen in rounded atelectasis. CT scan shows a 3-centimeter rounded lower lobe mass, pleural thickening with bronchomascular markings, coursing from it towards the hilum and a curved path. Bronchomascular markings coursing from it towards the hilum and a curved path. Tortoise sign, diagnosis, rounded atelectasis. Okay, this is question number 20. For 3-year-old female, Church-Strauss syndrome has high resolution CT, where most likely findings are small central lobular nodules. Now, this Church-Strauss syndrome, Persian peripheral cholestasis, okay, this is Church-Strauss syndrome. And there's small central lobular nodules. The nodules did not touch the periphery, they are all small central lobular nodules in Church-Strauss syndrome. In Church-Strauss syndrome, there are small central lobular nodules on CT scan. Next question number 21. A chest radiograph shows a figure 3 indentation of the aorta and atrial rib notching. Diagnosis, coarctation of aorta. This we have seen before, that when there is a figure 3 sign of the aorta and diagnosis, coarctation of aorta. There also has rib notching. Question number 22. Multiple red vascular skin blemishes. Diagnosis, hereditary hemorrhagic telangiectasia. This is also simple. If the patient has clinically multiple red vascular skin blemishes, diagnosis, hereditary hemorrhagic telangiectasia. Question number 23. CT scan of the neck and thorax shows the thickening of the arterial wall of the aorta and major vessels with irregular stenosis, lesions throughout the aorta, with focal areas of dilatation and stenosis, the brachiocephalic arteries and carotid arteries. In the brachiocephalic arteries and carotid arteries, diagnosis, Takayama arthritis. Look on CT scan, they're showing thickening of the arterial walls of the aorta and major vessels. It is all thickened, descending aorta wall is all thickened. And then there's some places there's stenotic narrowing. Also there's, look, this subclavian artery has thickening and minimal amount of stenosis. So this is called Takayama arthritis. These are showing Takayama arthritis. There's stenotic areas in the major vessels and the aorta, for the stenosis in part of stenosis in aortic aorta arch. Next, so that goes Takayama arthritis is medium to large vessel vasculitis. This is small vessel vasculitis, polyarthritis nodosa. This is polyarthritis nodosa. Both of these are polyarthritis nodosa. These are small vessel vasculitis. Now look that in this image, aneurysms are bigger than the size of the artery, so you can easily see it. But in this image, the aneurysms are smaller than the lumen of the artery size. So but we have to be ready for any image. So this is also polyarthritis nodosa due to small vasculitis and aneurysm. These are the polyarthritis nodosa. In this, we have to see the small aneurysms. Question number 24. The bronchial tree receives blood from one right and two left bronchial arteries. From which vessel does the signal right artery rise? It is a third posterior right intercostal artery. Remember that it is a third posterior right intercostal artery because remember like this, that the signal right artery usually rise, then CHIRD for right, the third posterior right intercostal artery. The signal right artery usually rises from the third posterior right intercostal artery. Question 25. Polyarthritis nodosa, acute left loin pain, seen on our sound scan, multiple renal artery aneurysm and perinervic collection. Okay. Multiple renal artery aneurysm and perinervic collection, polyarthritis nodosa. Correct? Multiple renal artery aneurysm and collections, multiple renal artery aneurysm collections, polyarthritis nodosa. Multiple renal artery aneurysm and perinervic collection, polyarthritis nodosa. Multiple renal artery aneurysm and collections. Question 26. CT scan shows transverse colon protruding through a small defect anterior in the diaphragm in a partial position, diagnosed with myocardial hernia. We've already seen this many times, that the transverse colon protruding through a small defect anterior in the diaphragm in a partial position, diagnosed with myocardial hernia. Question 27. Blood shows eosinophilia. Chest radiograph shows two areas of peripheral consolidation A further test radiograph 2 days later shows these to be dissolvent. Diagnosis Laffer syndrome. Where Laffer syndrome is simple pulmonary hemophilia, is a type of pulmonary hemophilia that typically presents with transient radiographic infiltrates, minimal constitutional upset, and elevated eosinophil count in the peripheral blood. Okay. Now, blood eosinophilia chest radiograph shows 2 areas of peripheral consolidation. A further chest radiograph 2 days later shows these to be resolvent. Diagnosis Laffer syndrome. Question number 28. Intravenous drug user shows has systolic murmur. Most appropriate next investigation, transesophageal echocardiogram. Because intravenous drug user, when he has systolic murmur, we suspect infective endocarditis. So we do next transesophageal echocardiogram. Next question number 29. Pain in the left arm when exercising, suspect subclavian steal syndrome. What is most likely to happen to the flow in the vessel during patient exercise to reproduce the pain? Reversal of flow in the left vertebral artery. This is also simple. When the subclavian steal syndrome, what happens to the flow in the vessel during patient exercise to reduce the pain? Reversal of flow in the left vertebral artery. Question number 30. Patient has blood tract trauma. Weak finding acuity would be more suggestive of the diagnosis of tracheal injury. Focal or distension of endotracheal cuff. Tube cuff. Now, it's also simple that when patient has blunt chest trauma and on CT scan, what would be suggestive of tracheal injury? Focal or distension of endotracheal tube cuff. This is simple, easy. Question number 31. CT scan shows 4 cm right middle lobe mass of pleural tethering with no chest wall invasion. Second, lung cancer staging. We have read this before. Remember that T1 is T1 less than 3 cm, T2 3 to 4 cm, and T1 less than 3 cm, T2 3 to 5 cm, and T3 greater than 5 cm or 5 to 7 cm. T4 will be metastasis. So 4 cm right middle lobe mass, it will be in T2, but no chest wall invasion, with 12 touching but no chest wall invasion. This node are seen in the right annulum, 17 mm short axis, in the subcranial space 20 mm short axis. So 2 lymph nodes and 2, and what is the T and M staging? No metastasis, so T2 and 2 and M0. Question number 32. These are the following findings of concern with regard to metastatic disease: focal power vertebral muscle uptake. It is likely that the patient has FDG PET scan. So after FDG PET scan, the normal uptake is seen in brain, thyroid tissue, kidneys, but there is no paravertebral muscle uptake, and if there is diffuse paravertebral muscle uptake, then that also may mean that it is physiologic. But if focal vertebral muscle uptake is seen, then it may denote a tumor or a foreign mass, which may be metastatic disease. So focal vertebral muscle uptake may suggest metastatic disease. Question number 33. Tuberous sclerosis patient undergoes embolization after 48 hours. She presents again with flank pain and is found to have a large perinephric hematoma on the site of the embolization, most likely caused post-embolization rupture. Now, after embolization, the patient again, if he presents with a large perinephric hematoma on the site of embolization, most likely caused post-embolization rupture. And after embolization, the most common complication that occurs in the first 6 months is post-embolization rupture. We just read it here. Post-embolization syndrome. Commonest complication occur in the first 12 months following embolization. Post-embolization syndrome. And patient undergoes embolization after 48 hours. She presents again with flank pain and found to have large perinephric hematoma, most likely caused post-embolization rupture. Question 34. In ventilated perfusion scintigraphy, suggestive of an intermediate probability of pulmonary embolism, large segmental match effect with similar size opacity on the chest radiograph. Now, intermediate probability of pulmonary embolism is large segmental match effect with similar size opacity on the chest radiograph. So, if there is a large defect, if the intermediate probability, remember like this, intermediate probability, then the defect will be large match defect. If there is low probability, then the defect will be intermediate. and if there's high probability, then there will be either multiple defects or uh, large defects, multiple large defects, or memorize it like this. So either VQ scan will show uh, high, intermediate, or low probability. If the defect is large, then there will be intermediate probability, and the defect is intermediate size, matched defect, then there will be low probability. Question number 34. Superior syndrome. CT scan shows irregular mass in the superior meningioma. Most appropriate next step in the pain management of brain tissue diagnosis. 2. Characterize the mass. If superior syndrome, there is irregular